All right, this is our final topic. We are looking at psych medications. So the first set we're going to talk about are medications for anxiety, trauma, which to start with, we're going to look at our benzodiazepines and our non-benzodiazepines. Okay, so we talked about benzodiazepines a little bit when we talked about neuro, and we talked about using them in adjunction with anesthesia. This can also be used as a anti-anxiety medication like alazepam and lorazepam, which is your that's like your Xanaxes, if you've ever heard of that. One med that I really need y'all to know is this chlorodiazoxide. Students usually struggled with this one because it doesn't follow the normal rule. It doesn't end in lam or pam, which most of them do. But it does have diaz in it. And if you think of diazepam, and it falls in the same category. This is a long-acting benzodiazepine, and it's really used for alcohol withdrawal because it's more long-acting and can help get them through the detox. But of course, it can be used in PTSD. It can be used in seizures and insomnia, muscle spasms, and anesthesia. But big time, alcohol withdrawal. You're going to see it a lot with alcohol withdrawal and PTSD and anxiety. So same deal when we talked about it before. CNS depression, amnesia. You can get a paradoxal reaction, hypotension, tachycardia, respiratory depression, tolerance, and dependence from overdose and toxicity. So we would get a withdrawal effect with this. So the big thing with this is that you don't want to take it regularly. It should only be used PRN. Okay, so that one's pretty big. So key points, big pieces. Our antidote is flumazenil, and a big thing too, if your client is alcohol withdrawing, or they tell you, even though we know they should only take it PRN, they have taken it every night for the last 6 months, your priority as the nurse is to get them in order for a benzo, because you are not about to go into overdose on my watch. So if they do take it regularly, you want to prevent an overdose, or I'm sorry, prevent a withdrawal. So that's pretty big right there. Then we have our non-benzodiazepines. So this is less sedating. This is Buspar. The one that we look at is buspirone. That's the generic. It's used for generalized anxiety disorder. It can have some paradoxical effects. GI dizziness, lightheadedness, headache. Biggest thing is this is taken every day, not PRN. It has to be taken daily in order for it to work. So yes, that's your big thing for buspirone, is to make sure that they take it every day. That's their education. All right, so now we're going to move on to depression medication. These medications, I know it's a lot. Just take them one group at a time. All right, so our first one is our tricyclic antidepressants. Amitriptyline, nortriptyline, all of them end in triptyline. Okay. How one of the YouTubers tells you to remember it is amitriptyline. Because it causes drowsiness, sedation, orthostatic hypotension, so it makes you fall, things like that. So let's highlight those. Can cause anti-chlorogenic effects, and it does cause withdrawal symptoms if it's stopped abruptly. But this medication is very deadly in overdose. So here's the problem. When we treat a patient, it is usually a few days before effects are seen, but it can be weeks until their depression has been touched on. So what happens is they are at increased risk for suicide because when they were super depressed and they were in the bed, they didn't have the motivation to get out of the bed. Now we have given them the motivation and the energy, but they're still depressed and want to die. So they are at risk for actually attempting and possibly completing a suicide when we start them on antidepressants because of how long they take to work. Typically, you're seen regularly in the office, things like that. So, of course, increased risk for suicide, I just talked about. Risk for falls. We talked about with the drowsiness, sedation, hypotension. Amy trips a lot. And it takes 10 to 14 days until effects even begin to be seen. So that's something you want to educate your patients on, because a big thing that we see in psych is that patients start taking the meds and 4 or 5 days later, they're like, you can start getting side effects within 4 or 5 days, but you're not going to see positive effects. So they start taking it and they're like, this medicine isn't doing anything for me, and they stop taking it. So we have to remind them that it does take a while before we can see progress with these medications. Okay, so now we have our selective serotonin reuptake inhibitor. This is our SSRIs. Fluoxetine, which is Prozac, citalopram, which is Lexapro, paroxetine, which is Paxil, and sertraline, which is Zoloft. Those are the main ones. I usually see sertraline, paroxetine, and fluoxetine. Used. Like in ATI, I see those ones come up a lot. They're used for a whole bunch of different things, but the biggest thing that this medication treats is, oh, that was big, depression, is depression, because, is depression, and we'll talk about why that is. So, of course, we're treating major depression, right? Bipolar, which you'll learn more about next semester or at the end of MedSurg 1 when y'all talk about mental health. Bipolar disorder has a piece of bipolar is depression, so this would help the depressive episodes of bipolar. It does help with obsessive compulsive disorder because of that anxiety that it does help with. It does help with anxiety a little bit, which is why it helps with some eating disorders, because eating disorders are typically rooted in anxiety. And then premenstrual dysphoric disorder is based on it's very, very bad PMS. So it helps with that serotonin release and helps prevent some of those hormonal changes. Okay. These SSRIs, they are quote unquote uppers, if you think about them that way. So they're going to wake you up. So I have a lot of students that tell me they take their SSRIs at night and it confuses them. Per ATI, you want to take them in the morning. Draw big old happy sunshine. Okay. And I know that is the most ghetto looking sunshine on the planet. Sorry. But you take it in the morning because of the insomnia, nervousness, things like that. Big things that we see, sexual dysfunction in men and women. So this, that's something to look out for, tell your patient about, and it would be a reason to switch them off of it if it's affecting their life that much. Headache is common, weight gain is common, and again, we talk about that increased risk for suicidality that we already talked about. And then we have serotonin syndrome. So serotonin is a normal chemical in the body. We are adding more of it to the body. We are making our body hold on to more serotonin. That is our goal. So what happens is if we have too much serotonin, we can go into what's called serotonin syndrome. So serotonin syndrome can be life-threatening, and we're going to see things like confusion, difficulty concentrating, fever, agitation, anxiety, hallucinations, incoordination, hyperreflexia, diaphoresis, tremor, and then they slip into a coma and die if we don't do anything about it. So we gotta be careful with that. So some things that you're gonna hear or see in your readings and as you do ATI, of course, you don't want to mix this medication or any of them with any other medication that increases serotonin a lot. So back when we talked about in neuro, we talked about the triptans, the sumatriptans. Those work by working with serotonin and increasing it as well. So you would not, if you were taking a SSRI every day, you should not take sumatriptan because you are at risk for serotonin syndrome. A lot of these medications, as you look through them, some of the client instructions or administration is going to be, or interactions are going to be other medications that causes increase in serotonin to prevent the serotonin syndrome. So the serotonin syndrome, increased risk for suicide, and sexual dysfunction and weight gain, and take it in the morning. Those are your key points. Okay. So now we're going to have a SNRI, a serotonin and norepinephrine reuptake inhibitor. So now all we're doing is we're increasing two chemical receptors. So instead of just taking just increasing serotonin, we're also increasing norepinephrine. This is going to be our venlafaxine and our duloxetine. Again, same deal. They work on depression and anxiety disorders pretty well. Our complications are going to be nausea, vomiting, anorexia, headache. So with the anorexia, we would not want to give this to somebody who has a history of an eating disorder. Insomnia, nervousness. So once again, I'm going to draw a nice little ghetto sun here. I'm going to have to take it in the morning. Okay. And it does cause withdrawal symptoms with abrupt discontinuation. All of these meds you do not want to stop abruptly. You want to taper. And then increased risk for suicide and serotonin syndrome, which we've already talked about. Okay, so MAOIs, we have already talked about these, so you should already know all of them. So we've talked about siglanine when we talked about Parkinson's. Another drug is finlazine. Oops, that's really dark. Finlazine. So really we're just adding another drug. Everything else is the same. So our uses, this is going to be things, any kind of depression, that hasn't responded to another drug. MAOIs are going to be our last stitch effort, our last course, because of how damaging it can be. So, of course, we have our normal side effects, which is orthostatic hypotension, anxiety, insomnia, and agitation. This is where my students get messed up because they get hooked on this orthostatic hypotension. But we can also have a hypertensive crisis if it's mixed with the wrong things. And we'll talk about that in a second. Again, suicide ideation. So just like with our Parkinson's drugs, no tyramine, which is going to be your aged cheeses, not cream cheese, not cottage cheese, aged cheeses. Pepperoni, salami, avocados, figs, bananas, fish, protein, soy sauce, soup, beers, wine, anything. Your diet is so restricted on these. That's why we try not to utilize them. So, talking about this hypertensive crisis. So there are two big issues with this medication. You can mix them with a decongestant, like the pseudoephedrine that we talked about in the respiratory system, or the antihistamines like your diphenhydramine, and you're going to get a hypertensive crisis. Or if you mix it with another antidepressant, you're at risk for serotonin syndrome. So, and this medication lasts in the body a while. The big thing is, so say they stop, they have to be off of one antidepressant for a full 2 weeks before they can start an MAOI. And if they come off of an MAOI, they have to be off of it for 2 weeks before they can start anything else. Big thing to remember when we talked about OTC herbal, St. John's wort, increases serotonin. It is a herbal supplement that can be used to help with depression. So St. John's wort would increase your risk of serotonin syndrome and any of these drugs that we've talked about. So atypical antidepressant, it can be used as an alternative to an SSRI or an SNRI when other medications have not worked. It is also used for smoking cessation, so you'll see this again here in a few. Okay. Big things with this, it can cause headache, dry mouth, GI distress, increased heart rate, hypertension, insomnia, nausea, vomiting, anorexia, weight loss, seizure. So of course this one we would take in the morning. Okay. Biggest one, of course, with the seizures. This med is also known as, the brand name for it, I'm sure y'all have heard about it, is Wellbutrin. It is being used now, in addition to depression and smoking cessation, it is being used for weight loss because of the anorexia and weight loss that it causes. Trazodone helps with depression because of the chemicals that it affects, but it's usually an adjunct for depression, meaning that you're on a depression medication and you use this one to help and you take it at night. See if I can draw a moon. It ain't bad. You're going to take it at night. It is used to treat insomnia. So a lot of times depression and anxiety come with insomnia, so this kind of helps. You can get priapism, which is that prolonged erection, so you gotta educate on that. It can cause sedation because it's indicated for people who have insomnia, of course. And you cannot have grapefruit juice with it. Okay. All right, so now we're gonna look at bipolar meds, and only one of these meds are new. Okay, so lithium. Lithium is a medication that's used to treat acute mania and acute manic episodes in bipolar disorder. It can cause GI effects, which go away with time. Muscle weakness, drowsiness, headache, confusion, polyuria, tremor. It can be a normal side effect or a sign of toxicity. Okay. It can also cause a goiter caused by hypothyroidism. Okay. So toxicity is very easily, it's a narrow therapeutic range. We've talked about that before, kind of like when we talked about with phenytoin. Your normal range is 0.6 to 1.2. This medication is filtered through the kidneys and it causes polyuria. So you want to instruct the client to drink 2 to 3 liters of fluid per day to prevent dehydration and keep their kidneys safe. They need to report signs of hypothyroidism, neck swelling, recognize toxicity, and consume adequate amounts of sodium because of the polyuria as well. So you have a patient taking lithium. Some things that you're going to want to look at: their lithium level, of course, their BUN and creatinine because of their kidneys, their thyroid panel, so the T3, T4, and TSH, and their sodium. Those are the big things that you're going to want to do, and I will do my very best to write that, but I know it's going to be hard. So I'm going to go ahead and do drug level, BUN, creatinine, drug level, BUN, creatinine, sodium, and thyroid panel. Okay. And that's it for lithium. All right, so anti-epileptics: carbazepine, valproic acid, and lamotrigine. We already talked about this. So when we talked about anti-epileptics, just because I'm using them for a mood stabilization, nothing changes. Carbazepine still causes blood to crisis. Lamotrigine, still you're still at risk for Stevens-Johnson syndrome. Valproic acid, it's still very tetragenic and still affects the pancreas. None of that stuff changes. So just go back and peek at that. All right, so now we're going to talk about medications for psychotic disorders such as schizophrenia. Okay, so I'll give you this little lecture only because I know you need it for other classes. Psychosis can be looked at as positive and negative effects or symptoms. Positive, when I say positive and negative, don't think about good and bad. Think about plus and minus. That's why I use the plus and minus sign. The plus, the positive, where you have a plus, things are added that should not be there. Abnormal things have been added, like delusions, hallucinations, paranoia, things like that. Whereas in negative symptoms, take away, minus, things that a normal person should have, this person does not have. Social withdrawal, no emotion, flat affect, no motivation. So that's just a little basic. I know you need it for the mental health proctor. I know you need it at the end of MedSurg 1 when y'all talk about mental health. So just thought I'd throw that in there. Okay. Another thing that we need to talk about is neuroleptic malignant syndrome. We kind of talked about this a little bit. It is the exact same thing as malignant hyperthermia, except the cause is an antipsychotic instead of an anesthetic. So instead of being caused by surgery medications, it's caused by a psych medication. Everything else is the same. High-grade fever, fluctuation in blood pressure, dysrhythmias, muscle rigidity, diaphoresis, increased heart rate, change in level of conscious, seizure, die. So we're going to stop the med, give cooling blankets, cool them down, give antipyretics, give diazepam for the possible seizure, and dantrolene for the muscles. So we've already kind of talked about this. It just has a new name. Okay. The next thing that I need to talk about is EPSs, extrapyramidal side effects. These are also called movement disorders because that's the side effect is an abnormal movement. So we have acute dystonia, which is the spasming of the tongue, neck, face, and back. We have Parkinsonism, which is where you don't have Parkinson's, but you have the movements of someone who does. Slow movement, rigidity, shuffling gait, drooling, tremors, etc. Akasia, where you're unable to sit still, you're pacing, you're agitated. Tardive dyskinesia, which is lip smacking, head moving, other involuntary movements, and they can be very painful. I do want you to know, just because I think it comes up in your stuff, there's a drug called benzotropine. This is not a benzo. This is what you would give somebody to treat an extrapyramidal side effect so it does not get worse and does not become fatal or permanent. So there are two things in here that are in red, and these are things that are life-threatening. Neuroleptic malignant syndrome we've already talked about. Acute dystonia is considered a life-threatening EPS because when the neck spasms, in the neck is your larynx and your pharynx. If those things spasm and get cut off, your airway has been cut off and you can die. So that is why this one is an emergency. Okay, so now let's talk about our medications. So we have what's called conventional, traditional, or first-generation antipsychotics. Chlorpromazine and haloperidol. These medications only control positive manifestations, so hallucinations, delusions. They don't do anything for our negative symptoms of schizophrenia. These ones have a huge risk of EPSs, neuroleptic malignant syndrome, and then also anticholinergic effects, dysrhythmias, photosensitivity, things like that. So big things for this one is you're at high risk for all of your bad side effects, dysrhythmias included, and they only treat the positive manifestations. Okay. So then we have atypical antipsychotics, also known as second or third generation antipsychotics. I need you to be able to recognize all of them, and I need you to be able to really pull this one out of a bunch. So risperidone, aripiprazole, quetiapine, and olanzapine. They have less side effects than the first generation. Now, you can still get extrapyramidal side effects, and you could get neuroleptic malignant syndrome. It's just less likely. Okay. And these ones treat both positive and negative manifestations. Okay. This drug, they can make you very drowsy. They can cause insomnia. It kind of depends. You can get dizziness, so we want to watch out for falls. Extrapyramidal side effects, and a big thing right here is the what is called metabolic syndrome, meaning that you can gain weight, you can get a new onset of diabetes or lose control of your existing diabetes. You can have your cholesterol levels can go out of control. So those things need to be monitored. Big thing that HCI loves to look at, clozapine can cause agranulocytosis. And all of these are contraindicated in dementia patients. Okay. All right, so now we're going to look at substance use. So, drug of choice for alcohol withdrawal, so meaning somebody usually drinks a lot and now they're suddenly not, they're going to withdraw. We talked about our drug of choice being benzos, and the one that ATI loves to look at is the chlorodiazepoxide, and that is because it's a long-acting benzo. So you can have alcohol withdrawal, or you can have alcohol withdrawal delirium. I don't need you to really know this too much. Just know that withdrawal delirium is fatal, can kill you. And someone who's withdrawing for alcohol, everything's going to go up and they are at risk for seizures. You will need to know this for your mental health stuff. So good thing, just something to keep in your back pocket. But I need you to know someone withdrawing from alcohol or at risk for withdrawing from alcohol needs a benzo. Okay. And then we already talked about that in the anxiety section. Okay. So now, once we have somebody who is an alcoholic and they've come in and they've detoxed and they have made a commitment that I'm no longer going to drink, I want to get better, go into a 12-step program, all of that good stuff. That is when we're looking at alcohol abstinence, staying away from alcohol. So there are a couple of different medications. A big one that you'll see is disulfiram. This is aversion therapy, meaning you do it and bad things happen. So if you drink alcohol while on this drug, you get sick as a dog. It's called a acetaldehyde syndrome, where you get nausea, vomiting, palpitations, hypotension, and it can progress to death. So we need to educate our patients. They cannot drink with this. We need to talk about danger of relapse on medication. Like if they relapse and go back to alcohol while taking this, it can kill them. This can absolutely kill them. So they need to be aware of that. Another issue that we have that we need to educate our patients on is what I call quote unquote secret or hidden alcohol. So, just like we talked about, our body doesn't care what we're using a medication for, the side effects are going to be the same. Same thing, your body doesn't care that the alcohol that just went in your body was mouthwash and not a gin and tonic. It's still alcohol and it's going to cause the same thing. So mouthwashes, they need to have alcohol-free mouthwashes. They need to check any kind of hot sauces, things like that, because they do have alcohol in them. Hand sanitizers, cold meds, and cough syrups have alcohol in them. And this can be very easily done. I have seen this when I was actually doing a clinical rotation. We were there, I was on a substance use unit, and someone was on this, and they literally used hand sanitizer on their hands, not thinking about it, touched their mouth, and they had to get shipped off to the emergency room. So you gotta be very careful. And because of that, they need to wear a medical alert bracelet. Okay. The next one we're gonna talk about is naltrexone. This med is really good for decreasing cravings and decreasing pleasurable effects. So this medication, its FDA approved use is for abstinence from alcohol and opioids. But because how it hits the pleasure receptors in your brain and makes these things not as fun, it makes these things not produce the dopamine and all that happy drug that it used to. This is used for gambling addiction. This is used for food addiction. Lots of things. So of course we want to take an accurate history and make sure that they can abstain from these things. And we want to take it with food because of GI upset. And if they cannot adhere to daily treatment, monthly IMs are available. Okay. And then a compressate is just decreases the effects of not having an alcohol, like the sweating and the anxiety and the restlessness. But it does cause diarrhea, and it has to be taken 3 times a day with food. So that's a lot of taking it. And stay hydrated and rested, especially because of the diarrhea causing dehydration. And don't use it in pregnancy. Okay, so now we have opioid withdrawal. So opioid withdrawal occurs a few days, 1 hour to several days after opioids are stopped. You're going to have things like agitation, insomnia, flu-like symptoms, sweating, piloerection, which is goosebumps, stomach cramping, diarrhea. These symptoms are not life-threatening like alcohol withdrawal is, but they do make you wish you were dead, so it can cause suicidal ideation. So we got to monitor that. Okay, so our main drugs, of course, opioids. If someone is in an active opioid overdose, we're going to use naloxone, and that'll send them into alcohol or opioid withdrawal. First med we're going to talk about is methadone. This is a trading card game, essentially. Legal opioids replace the illegal opioids. So the goal is to prevent withdrawal symptoms. Your dependence to the illegal opioids, heroin, what have you, is transferred, and you are now dependent on methadone. So you have to go to the methadone clinic every single day to get your dose. We need to make sure that we ensure withdrawal symptoms are not happening because clients may not be honest about their usage, so we may not be covering them enough. It's a very slow taper, of course, and like I said, it has to come from a methadone clinic, so a approved treatment center. So not just, this isn't a prescription you can take home with you and take every day. Okay. Clonidine, which we've already talked about in the heart section, can mask the effects of diarrhea, nausea, vomiting, does not reduce cravings, but helps mask just like the acompressate does for alcohol, this does for the opioids. Of course, we want to get baseline vitals because it can drop their blood pressure, can cause drowsiness, dry mouth. Those are the big ones. All right, then you have buprenorphine. Some people may know this one as You may know this as Suboxone. This is a opioid agonist antagonist. So remember, it kind of does both, so it's a lot safer. That's why it's considered methadone, because it has that antidote in it. Substitutes the opioid, decreases the cravings, used for withdrawal and maintenance, and you can come off of it. I've seen someone successfully come off of this and stay clean. Has less respiratory effects, less dependence because of that part being a partial, instead of being a full opioid agonist. It's an agonist antagonist. And we have less effects, and it can come in many forms. It comes in sublingual, oral tablets, and implants. The implants are, just like we talked about before, if you can't adhere to a daily medication, you can get an implant. And it can be taken at home. So that's the other benefit of this. So now we have nicotine withdrawal. Everything kind of goes up when you're withdrawing from nicotine. And we have a couple of things that we can talk about. So varenicline is your Chantix. A lot of people have heard about this one. Biggest thing is it reduces cravings and withdrawal and reduces relapse. This is actually one of the most successful smoking cessation drugs when they don't have terrible side effects. So, big things is you have to titrate it carefully. It has everything in it that you need. But you can have insomnia, depression, and SI, and can have neuropsychologic effects like unpredictable behavior, mood swings, suicide. So it is banned for anybody who does things like drive commercial vehicles, drive buses, pilots, drive people in a plane through the air, because it can cause that unpredictable, unstable behavior and make you do something harmful. So yes. Bupropion, we already talked about. This is your Wellbutrin. It is a stimulant, so we want to avoid caffeine. And then nicotine replacement. Nicotine replacement is you replace the nicotine that you get from cigarettes and chewing tobacco. So these are those Nicorette gums, lozenges, the nicotine patch. They actually have nasal sprays and inhalers, things like that. Okay. So the last two things I want to talk about is a medication for sleep and a medication for glaucoma. And this one's going to be super easy. So zolpidem, it starts with a Z, and just think someone sleeping, snoring, and the little Z's coming up. This is the brand name for this that you may know it by is Ambien. It's for short-term management of insomnia. It can cause daytime sleepiness and lightheadedness. It can cause headache and sleep activities. People have been, it says sleepwalking, but people have been known to get in their car and drive somewhere while they're asleep, have sexual intercourse while they're asleep, have full conversations, go out and do things. Someone had to get pulled out of a swimming pool. They went swimming. So sleep activities. So that can be really harmful. Big things is you want to give it at bedtime and allow for at least 8 hours of sleep. This is not because of how tired you would be. This is not something you would want to take when you are studying for a nursing exam till 3 in the morning and then have to be up at 9 for class. So you want to make sure you get at least 8 hours of sleep, and it does absorb more rapidly when taken on an empty stomach. So if you do take it with a meal, it's going to stay in your body longer and make you sleepy for longer. Of course, with this being a CNS depressant, making you go night-night, you don't want to mix it with other CNS depressants like benzos, alcohol, things like that. All right, and last but not least, we have a beta blocker eye drop. The big one is called Timolol. And it still has the same ending as our beta blockers, OLOL. But instead of being used for blood pressure, it's used for glaucoma and increased intraocular pressure. So pressure behind the eyes. Big things is a burning sensation in the eyes. So you got to tell the patient about that. And a systemic effect. So ideally we put the eye drop in our eye and it just affects our eyes. But remember when we talked about eye drops, you hold the nasolacrimal duct or the bridge of the nose for a minute. That's to help prevent systemic effects. It's not 100% foolproof, but it does help. You hold the duct, but the big thing is you want to remind them that systemic effects can still occur, which would be all of our effects of a beta blocker. A drop in heart rate, a drop in blood pressure, which would make you dizzy and make you at risk for falls. Okay, so nothing really changes there. It's just a new way of giving it. All right, and that is it for these medications.